Good afternoon, and welcome to Taking a Holistic Approach to Your Connected Devices Security, a Health System CIO Media Inc. production sponsored by Armis. Just a little housekeeping before we get started. My name's Anthony Guerra. I'm the editor-in-chief of Health System CIO, and I'll be your moderator today. We're looking forward to your participation. You can send in your questions or comments in the Q&A box, and we'll take those later in the program. Just so you see how we're going to spend our time today, we're going to go about 40 minutes with our main panel discussion featuring Renee Broadbent, CIO at Southern New England Healthcare, Christopher Friends, CISO and AVP of IT Security at Mount Sinai South Nassau, and Mo Wakas, Principal Solutions Architect for Global Healthcare with Armis. And then we will have our Q&A. So let's jump right in. Renee, let's start with you. Can you give us an overview of your organization and your role?
Yes, absolutely. My name is Renee Broadbent, and I am the Chief Information Officer as well as the Information Security Officer for Southern New England Healthcare Organization, otherwise known as SON Healthcare. We are called a clinically integrated network, or CIN. And so we cover areas in Connecticut and Massachusetts. And what that means is we have a large management of population health folks. So we have about 17 different contracts that we have with different payers, Medicare Advantage, SSP, and we have about 200,000 lives under management. So, and we are affiliated with Trinity Health of New England. They are part owner of our clinically integrated network, with our physicians owning the other 50%. In my role there, I'm responsible for all of the data that comes into our organization, the dissemination and medical economics of that data, and then also, and most importantly, all the security of that particular data, as well as everybody who connects into us. So it's a pretty broad network, and I'm happy to be here today with my colleagues to share how we can, our best ideas about how to protect all that.
Very good. Thank you so much, Renee. Chris?
I'm Chris Friends. I'm the AVP of IT Security for Mount Sinai South Nassau, which is a hospital system based in Long Island, New York.
Excellent, Chris. Thank you. Mo?
Hey, everybody. Mo here. I'm the Principal Solutions Architect for Armis. I lead the Global Healthcare Division at Armis. We're an industry-leading medical device security platform. Prior to Armis, I spent about a decade building an information security and privacy program for a hospital from the ground up. So everything from bringing in technologies, dealing with ransomware attacks, governance, and maturing the program. So really excited to be here for this conversation.
Excellent. All right. Let's jump right in. Renee, we're going to start with you. Talk about the breadth of devices, both clinical and non-clinical, that could be connected to a health systems network. Do you think that some of these, even though they represent attack vectors, are being overlooked by security professionals?
Yeah, so there's lots of different devices in my role. So, you know, we have my health system colleagues spend a lot of time with the medical devices, right, that they have to connect. I have to worry about all the other people that are connecting into our system and the devices that they actually might be connecting to. So, I mean, it could be a medical device. It could be a wearable. It could be their cell phone. It could be laptops. I mean, there's any number of devices that could attach into the network. And even though I think that there are a number of things out there that security professionals potentially can overlook, and the reason is because I think the universe is becoming more diverse about what in, right? I think things are easier to get access to. And one of the things that, you know, we struggle with or continually stay on top of is really keeping that inventory, like who is trying to get in, right? Who needs access, and how do we protect that? And so I think that, you know, one of the things also to be mindful of is how to maintain control or get a handle on what those devices are going to be and how that changes constantly. You know, we're focused right now on a digital strategy, which opens up the door to a whole bunch of other devices and things that connect your network. And so that's something we'll be grappling with. And this ties right into that, right? What is out there? What is the universe? And is it possible that we're missing things?
And Renee, as you're saying, it's not just a one-time snapshot inventory. It's maintaining accurate inventory on something that's constantly changing, correct?
Yes, you know, and I'll tell you this, IT, confessions of an IT person, right? Everybody hates doing inventory. It's like the bane of your existence. However, you know, it's becoming more and more important. It's not just like, hey, how many people sensors do you have, you know, and where are they? It's really like, what is everything? What is the universe that's out there, and how do you proactively look at that? And what we do is we have a very structured security program in place, both internally. We partner with compliance, and that inventory piece is a part of it. And we have a cadence that we follow to make sure that we're, one, it's always current, but two, what's coming up on the horizon and what we need to look at and look for and put in place to do that.
Very good. Chris, your thoughts?
I don't disagree. Asset inventory is always a challenge. As someone who's done zero trust within 2 hospital systems now, asset inventory is always challenge number 1 for going down that pathway. I would just add a couple of other categories of devices too, because it was already mentioned, clinical devices, a lot of your typical non-clinical devices like PCs and printers. But I think what's also important in healthcare setting that's commonly overlooked is a lot of the operational technology devices. Because if you consider things like not just HVAC type controls, but even things like pressure sensors in an isolation room, that can have a huge impact on patient care if those begin to fail. Same thing with like humidity sensors in operating rooms. If the humidity gets too high or too low, it can increase the rate of infection. So there's lots of things that are not traditionally classified as a medical device that still have huge impacts on patient care. And I think a lot of times we don't give enough attention to those within healthcare security.
Excellent point. Mo, your thoughts?
Yeah, I think I'm going to be a bit of an echo here, but absolutely. When I'm talking to a number of different executives across healthcare organizations, what I love hearing is the fact that now medical device security, connected care security is starting to become part of that strategy. When you're looking at a cybersecurity framework like NIST, it's talking about assets, it's talking about business systems, and what we're starting to see is healthcare organizations expand that scope. That it no longer stops at a client server, it's also the peripherals that are connected, right? The wearables, the telemetry, the IOMT devices. I love, Chris, that you brought up OT and building management systems, because while there's a lot of consideration for the medical devices, what we're having a lot of conversations for with healthcare organizations is they have a really diverse device ecosystem, right? Point being those facility devices, the HVAC units, the IP cameras, the parking sensors, and so on. So a lot of times the patient will interact with 8 to 10 different types of devices before they even touch a single medical device. I think the other challenge where security teams might overlook certain devices, it also comes down to the context of how devices are being used. With IOMT, with vendors evolving that medical device profile, if you will, to leverage iPads as ultrasound units, right? By attaching peripherals and things of that nature, it's more important now than ever to understand that this is not simply an iPad on the network, but it's an iPad that's being used in the context of clinical care. So these shouldn't be moved off onto a BYOD network. They should rather be on the biomed network. So those are the types of trends that I'm seeing. And I think it's creating a problem for security teams, because now they're starting to be tasked with securing unknown devices or that they don't understand the workflow of, and traditional security tools that might be IP based and really based on the operating system and Macs, they tend to struggle with real identification of the devices.
Mo, let me ask you
Great.
something. You know, we have medical devices that are overseen by the FDA, right? And then we have, let's say, all the other stuff that doesn't go through the FDA. One of the issues with medical devices is you can't really patch them unless, you know, the vendor says it's okay, because, you know, you take on a whole bunch of liability. We don't have that same issue with the non-medical devices. Therefore, they're more patchable. Does that make sense? Or I don't know if the vendors are coming up with patches as quickly as need be, but you don't have the same issue when you take the FDA out of it, correct?
Yeah, you don't necessarily have the same impact, I'll say, where it's impacting patients, patient safety, and things of that nature. But on the flip side is that vendors do have certification for OT devices as well, right? But on the in terms of the impact, it's if that goes down, it's not as deep of an impact as being directly connected to a patient. But to Chris's point, there's a lot of ancillary healthcare services and connected to the delivery model that it'll impact. So we're seeing a similar level of patching restrictions on these OT devices that healthcare systems and generally the industry across the globe is trying to navigate. And we're seeing a lot more strides in, vendors that are releasing not only security advisories when it comes to these patches, but also understanding that because these are these vulnerabilities are found on legacy OSs that are no longer being patched, here's mitigations and here's workarounds that they're also starting to provide for both the OT side of the house and the IOMT side of the house.
Very good. All right, Chris, we're going to start with you on this. and we talked a little bit about this, is obtaining an inventory of network connected devices a crucial first step in getting one's arm around this challenge? And is this more difficult than it should be, and why?
I think it's definitely a challenge, and I do think it's an important first step. If you look at things like the CIS, top controls, asset inventory is always control number one. So I think in order to protect the stuff on your network, you first need to know what's on the network. But one of the challenges around it is if you have, let's say, 10 different tools deployed, you might get a different asset count from each tool. There's not always agreement. Certain tools may see things others don't. So taking the time to correlate all that data, figuring out what's what, it's not necessarily the easiest process in the world, but it's critical to know what's on your network. Particularly with a lot of the zero trust efforts I've done, because the challenge number one is always to figure out what assets are on the network. So then you can go to the next step and figure out how all those different assets talk to each other and map out all the different traffic flows on your network. And I think both exercises are of critical importance, because even if you don't ever go down the road of zero trust, if you know what kind of traffic flows are supposed to be on your network, it makes it significantly easier to identify any traffic flow that shouldn't be on the network. So from both an incident identification, incident response perspective, it makes a lot of stuff a lot easier. So in my opinion, it's definitely a key security control to figure out what's on the network, and a very, very worthwhile exercise to do.
Chris, why would different tools be giving you different counts? What are some reasons that happens?
I mean, a lot of cases because you might have different visibility. So, or for example, you occasionally say you're pulling numbers from, let's say, an antivirus type product. Maybe the agent failed or isn't working on a couple of PCs, so that gives you different counts, and over time that leads to discrepancies in tools. Or there's the possibility that you forgot to install, let's say, one particular tool or agent on a set of PCs in your organization, and it's easy to, I guess, know what's known, but not knowing what you don't know, or for finding that out is kind of the hard part. And a lot of that plays into coming up with a complete asset inventory, because you don't know what you don't know.
And do you like having multiple tools so you're getting different counts? If you just had one tool, would that concern you, or what are your thoughts around that?
I do think it's always worth having multiple tools to pull data from for asset inventory purposes, because you'll get a more complete picture. You'll often find different tools, see different things, and by correlating the data, you can discover devices on your network that might not have been there. Because reality is no tool is perfect. A lot of tools are very good, but I've never found any tool that 100% does everything perfectly.
Mo, what are your thoughts around inventory? And again, there's a couple issues here. It's the idea of different counts. So that's one issue. And then it's sort of maintaining an inventory. It's not just a one-time snapshot. It's sort of getting something real time where you're seeing things coming off and onto the network.
Mhm. Yeah, absolutely. And I think if I kind of put on my previous security practitioner hat at the hospital, two examples come to mind. Is whenever there was a 0-day patch or 0-day vulnerability identified, or something related to a ransomware campaign, even to probe enterprise devices, we're waiting for 30, 45, even 2 hours for additional devices to come online to be able to pull them. So in that time, we're still exposed to this massive ransomware campaign that's happening around the world. On the flip side, when it came to medical devices, we had to rely on the biomedical and clinical engineering teams, asking them, can you give us information on medical devices? Now, what did that result in? It took them about a week to do a complete site survey of all the different devices. And to Chris's point, this is what they knew about, right? This is perhaps what the departments informed them of, or they had directly purchased. But when that information came back, the information wasn't aligned with what security teams needed. So there's also a gap in the different information that different teams need and different tools provide. I think one of the other challenges is 10, 20 years ago, what have you, a lot of the, if not all of the IT purchasing or connected device purchasing was happening through the IT department, your laptops, desktop servers, things of that nature. What's happened now is IoT devices, IoMT devices come in, and we were on the receiving end where we're just getting calls from clinicians saying, hey, I have these 20 new glucometers that I've purchased. I need to connect them to the Wi-Fi. So what's the Wi-Fi password? Right. And that's how teams are getting notified in terms of there's new devices on my network, only because they needed some type of password that they didn't know about. Otherwise, and that's the trick here, and that's the challenge, is that blind spot is continuously growing, right? How do you know that you've reached 100% visibility if you're not in charge of all the purchasing? That's a lot of the conversations that we're starting to see, and the trends that we're seeing is you might be really good at the assets you manage and you've purchased, but nobody can say with definitively information about assets that they don't have, that facilities is purchasing, that biomed's purchasing, diagnostic imaging is purchasing, and so on.
And Mo, when finally the CISO or the CIO gets that call and says, "Oh, you know what? I think I better take a look at this device you've purchased that you're putting on their network," and they finally get to look at it, they may say, "This thing is a horror show, right?
Mhm.
I don't want this anywhere near my network." And they would have never known about it if they hadn't gotten that call, or if ultimately they didn't have a tool that popped up that there's 15 new devices on your network, and what are these, right?
Yeah.
I mean, is that how it plays out on the ground?
Yeah, exactly. That's one of the challenges with healthcare, is really shifting over from a reactive state to a proactive state. And I think that's some of the challenges with security teams, is that they might be being pulled in, when there's a change being approved for a go live project that they had absolutely no involvement in, that covered implementing these medical devices, implementing new innovative technologies, right? Renee mentioned going digital, even having cloud footprints. And at that point, security is kind of coming along and saying, whoa, we have no idea about this. We need to do our appropriate risk assessment. And that creates delays in, innovating that patient care. So that's one of the challenges, and one of the key, I think, to really getting proactive in securing hospitals, reducing attack surface, and enabling innovation, is to enable healthcare systems to take a much more proactive approach to security.
Renee, wherever you want to jump in there, there's lots of stuff.
Yeah, no. There isn't anything that, my colleagues have said, Chris or Mo, that, isn't a top of the mind. And just, speaking to about going back, the hospital, the centralized purchasing thing is huge, right? I can tell you how many projects I got called on. I'm like, hey, we just spent $1 million on X and we need access to the network, right? Don't know if it's compatible, don't know if it's secure. And you saw a lot of that. So an advantage I have is I'm in a little bit of a smaller footprint for security. So I can control the purchases, right? I can control the access to certain things until I get out to my, and each of my network practices might be implementing something else, like remote patient monitoring, that then wants to do an interface into something, right? And no, I'm just agreeing with both Chris and Mo, just saying, you have to really just use multiple tools to kind of go get your stuff and really understand that inventory. And, it's constant, it's a constant, looking proactively so that you can make sure you're completely covered.
Very good. All right. Let's go to our next question. And Mo, we're going to start with you. From a technical point of view, how can security teams be alerted each time a new device is connected to the network? So nobody called you and asked you for a password. People are purchasing things all over the health system. You want to know about that as the security leader. How can they be notified? And Chris alluded to this before in terms of traffic, but specifically when a device starts behaving in a way inconsistent with what it should be doing. So from a technical point of view, how's that work?
Yeah, absolutely. And some of this is talking about the Armis platform a little bit, but I think at the foundation of it is, to your point, exactly what you had mentioned. It can't be a snapshot in time, right? So a scan at Friday, 3 p.m., it's not going to give you the real-time view or the complete view into your environment. And a simple example of that is if you're doing scans at Friday noon, let's say, some of the users are going to either take half day, they've logged off for their lunch break, and so on. Now that these devices are offline, you're not going to be able to ping that IP and get a response or understand what device has that IP today. So at the foundation of the from a technical perspective, you're going to need a tool that does completely real-time discovery. And to Chris's point, this is going to be based on the traffic, right? When that device gets added on, it's reaching out to network infrastructure to grab some network information like having IP assigned. Even that part alone can give you visibility in terms of how many devices do I even have on my network, right? The other part is, given the sensitivity and criticality of different types of devices in a healthcare ecosystem, your medical devices, bedside monitors, ER devices, facilities devices that are running proprietary operating systems or can't have agents installed, there needs to be a passive approach to it. So that aggressive or active probing of devices, knocking on their door saying, hey, what kind of device are you? Give me more information about yourself. That's detrimental, I would say, for a healthcare organization. Just, one battle scar I've had is even doing a scan of like an interface bus. So even though it's running a Microsoft platform and what have you, if they're getting packets on ports that they're expecting specifically crafted messages from HIS systems or from protocols from medical devices, that can just hang the entire system because they're not sure how to process these packets or process any of this. That's why the active scanning component is fairly critical to make sure that it's more of a passive approach. As devices are being added, that's where it's going to be a continuous update. Hey, I detected new traffic from a new device. The alerting mechanism now, I think the healthcare organization is also facing alert fatigue. So you want to also make sure that from an alerting perspective, even setting the parameters in terms of what do I care that I want to be alerted on? Do I have different zones or boundaries or network segments set up that I really care about when devices are being added? If it's a non-medical device being added to my guest network or to being added to a vendor network or things of that nature, or based on specific traffic patterns, I want to be notified. Or if there's a high risk device that's being added. I think that's a key aspect here is security teams, you want to become aware of things that you can action and that you care about to help
Renee.
keep that alert.
Oh, I'm sorry,
Right.
Mo.
Okay, sorry.
Go ahead, Renee.
And that goes to risk classification, exactly what you're saying about what are those devices, right? So there may be things that are less risky, and then there's other things that you always want to be alerted to, right? So when you talk about non-medical devices, right, there's a lot of different things that can attach to your network that people may randomly think that that's okay to put those devices on your network. So I think having that risk classification identified and having a process for when that happens in terms of communication and outreach and having solid policies and procedures that are communicated about what that means kind of mitigates some of that. Sorry.
Yeah, Renee, one of the things that I've heard is, especially with certain, limitations in personnel, that the alert fatigue is real, especially in IT security. CISOs don't so much want another tool that sends them to investigate things they have no time to investigate. Right. So
Right.
that's why there's managed services can be attractive, because it's sort of, I don't want to just a tool that tells me about problems. I also want someone to deal with them for me.
Yeah.
But what are your thoughts around that?
Yeah, so I'm a perfect example of having a really small department. I have 3 people that basically work on my infrastructure side, right? And you do get alert fatigue. So, we don't use managed services. We actually, remove that process. We didn't outsource that anymore. So, we're trying to be innovative because we are small, but because our network is the universe, right? So what we try to do is come up with innovative things like, do we have a dashboard alert, and really kind of bifurcating what's important, what's critical, what's not, to reduce that alert fatigue. Because I don't have the luxury of paying somebody to sit there and just watch something all day long, right? And respond to every single alert coming through. So we do have to stratify that, and we do have certain protocols in place. A benefit that I have is we have our network is very contained, and a lot of our applications are outsourced, right, to cloud solutions, right? So we have other tools that we can leverage to help us do that.
Chris, what are your thoughts? What do you think about alert fatigue? Is it real for security folks?
I think alert fatigue can definitely be a real thing. And I think it's important to always take the time to tune alerts, to figure out what's critical to your organization. I think a lot of it can be reduced to if you can automate some of the processes too. Like one of the things I'm big on with a lot of the zero trust approaches is creating device-based profiles. So your system automatically recognizes, okay, this is a PC or this is a laptop or a printer, and it applies the appropriate policies automatically. So things like that can help reduce a lot of the types of things you get. It's also important to consider, as mentioned already by Renee, is the risk of the system. I might be more interested in unusual traffic going to or from a domain controller than, let's say, a different type of device in my environment, just because of the criticality of a domain controller to the environment. And knowing what's important on your network versus what's less important definitely reduces the amount of work. The one thing I will say with the zero trust approach is the more you start to take an approach like that and the more you start to actually lock things down, it actually reduces the amount of alerts you get. So one of the things I've experienced is the more we begin to actually lock the network down, the less we find we're triaging, the less incidents we're having, the less fires you're putting out, and that really helps with the alert fatigue. So it becomes kind of a really positive feedback loop, because the once you start to lock things down, your alerting goes down, which means you can shift security staff to actually locking things down even better, which further reduces your alerts, and it kind of snowballs from there.
Chris, you've you know, this was alluded to by Mo before on the passive versus active scans, and you've alluded to before about understanding your traffic flows before you go in there and start doing anything. And I think the point is, it's sort of in medicine, the idea is do no harm, right? Above all, do no harm. So from a security point of view, Chris, I think your approach is figure out what's going on before you go in and start monkeying around, right? So you don't want to break anything.
Oh, definitely. Yeah. And we've used a variety of approaches at different organizations. I've used a variety of approaches over the years to figure out traffic flows or anything else before I've applied those policies. For me, doing any kind of zero trust policy, it's a matter of breaking the environment down. So the approach I've always taken is I've always done a low hanging fruit first. Do things like DHCP servers, DNS servers in your environment. Every network engineer knows the ports and protocols. So the odds of missing something while applying those policies is pretty small, but that lets you learn whatever new tool you're using. So do low hanging fruit like that first. I've always been big on targeting the workstations in the environment next, largely because workstations tend to be clones of each other. So if you figure out one set of policies that work for a workstation, you can usually apply that to a large number of workstations in your environment. So it's a good way to get large coverage within your organization. I'm also big on doing workstations next, because if you think about it from a risk perspective, most cyber attacks still happen when somebody clicks on a phishing link or something else. So you're actually isolating and segmenting your biggest risk factor for next. I'm then usually big on doing the servers, mostly because that's where the most high value data is. And I usually save the IoT type devices for last, mostly because if you're segmenting your workstations and servers properly, you're also indirectly protecting all the IoT, because the average desktop should not be talking to, let's say, the infusion pump. So the workstation segment policy should kind of indirectly protect a lot of those IoT devices. And that's usually the strategy that I follow for segmenting a network.
And Chris, just real quick, again, from the things you've said and the way you describe your work, sounds like you have a philosophy that says, I'm going to do sort of a lot of work up front. I'm going to understand these traffic flows. I'm going to develop these device profiles. This is going to be a lot of work to get started, but I'm going to save myself a tremendous amount of work down the road once I get all this stuff in place.
It's a lot of work to get started, but I'm big on that for a couple of reasons. First reason is I'm very big on doing breach and attack simulation. And having done simulations of ransomware attacks and malware spreading through an organization, one of the things you see quite quickly that without very fine-grained segmentation, an attack can spread through your environment really quick. When I did my first ransomware simulation, which was back in 2015, that was at a hospital that had a network that was highly segmented by 2015 standards. It was segmented by department. So traffic from one department could not cross over into another department. And we tested it, that worked really well. But one of the things that really stood out is if we were to lose an entire department, it was still going to be disastrous to hospital operations. We can't not have an emergency room or not have a radiology department without it impacting patient care. And that's kind of what initially got me interested in zero trust. So that's one reason I'm big on doing a lot of upfront work like that. The second reason is the reality is medical devices for the foreseeable future have clinical lifetimes that are going to long outlive their supported operating systems. So, today's brand new medical device, well, the state-of-the-art security features is going to be tomorrow's legacy device. So we might as well put it in place with all the proper network segmentation, other compensated controls like DNS synchrolling, things like that, to leave it protected for the long term.
Very good. All right. Next question, Renee, we're going to start with you. So we talked about sort of some technical things from a governance point of view.
Yeah.
What processes and procedures can security professionals put in place? And we talked about this, things popping up only when you get asked for a password. We don't want that. We want to get ahead of things. So what, from a governance point of view, what can be done so those things get in front of IT security in a timely manner and are reviewed before they pop up on the network? How do you create, and part of getting that done is creating a culture where people don't see IT security as a dead end of projects, right? Well, don't bring it over there. They may find out about it later, but if you bring it over there, you're done. You're never going to hear back. We know that people are trying to change that culture. What are your thoughts, Renee?
So there's a lot to that question, but let me try to break it down how I see it. First of all, I think at a very high level, you need to have a culture of security awareness, right? And you have to, it has to be infused in your culture, right? So that way people are not afraid to talk about security, or they take proactive stances when they know they need help from security, right? And it could be as simple as, like if someone gets, I'm happy if someone, gets a phishing message and they send it to me saying, this came in my mailbox, right? Very, very simple, not related to a device, but starting to create a culture of security that it's okay. We need to be aware. It's not a bad thing. But I'm okay with talking to our people in security, asking questions. Hey, I'd like to get this device attached to the network. We've gone a long way in doing that. When I first joined the organization, I was resolving a data breach. It's public, so I can say that. But and in 2 years, we've put together a very strong framework in terms of the culture around security and the importance of it. That's one piece. The second piece is the governance around that, right? So we have a strategic security plan, and we have, I'm affiliated with a hospital, so we have a little bit of a structure where we have a committee, we have a security committee, we evaluate all these things, we have policies and procedures that deal with it, and then we report up to audit and compliance, right? We have regular audits that come in, external audits. And then, refreshing people, having them have training on this, like what is the importance of letting us know when you want to do this sort of thing, right? And in creating that framework so that, people don't feel like they have to wait, or they don't have to sneak around and get anything, for lack of a better thing. We almost never have bog downs in our security. I have a lot of people coming to me with, hey, I want to look at this, I want to look at that. I have a checklist. I'm like, you want this vendor, you want this whatever, here's the 5, 6, 7, whatever it is, I have a list. These are the things I need to know. If you don't want to call them, I will, right? And so removing the barrier for them and making it easy, and knowing that, we're really looking out for the best interests of the organization, our patients and consumers that we serve, and protecting them in the long run. So it takes a lot to do that. A lot of time on governance. We spend a lot of time, having not a lot of meetings, but a regular cadence, so that we're reviewing those things, and a reporting structure to make sure that, all the pieces that we put in place are endorsed at the highest level. And that's also, that'll be my last comment. That's the most important thing in my mind, is that you have support as far up as you can get it, so that it kind of, trickles down to everybody else.
Yeah, because then you don't get the end around, right? Then you don't get someone who just goes above you and gets something signed off on.
Right. And so our structure is, I report up to audit and compliance reports up to our board. So when we're endorsing these types of things, or rolling out these kinds of things, or communicating these types of things, we have now infused that throughout the organization and support at the very highest levels.
Chris, what are your thoughts? And specifically, I'm thinking around purchasing. Do you have a stopgap in purchasing where maybe there's a description of basically anything like this needs to be signed off by Chris before purchasing something? Like, your signature has to be on if it meets these criteria. Do you have something like that, or what can the relationship be between IT security and purchasing that'll help you make sure these things don't pop up on the network?
Oh, we definitely have a third-party risk management policies in place that require security assessments. Similar for medical device purchases, we do have an assessment process in place. In terms of outside vendors for third parties, we usually tier the risk. So we'll rate vendors from a high, medium to low risk, where a low risk vendor might be something, let's say, the external affairs department deals with, where it's all public facing data anyway. So if there's a data leak, it's not super critical to the organization because it was designed to be public. Whereas a high risk vendor was going to be a vendor that deals with PHI or other confidential data for the organization. And we have different levels of assessment that we put the organizations through based on which category they fall in. But we'll typically, we have our security assessment questionnaire. We'll typically ask for third-party verifications like SOC 2 reports, or other types of compliance like that, as well as pull some scores from some independent scoring agencies about those organizations. And depending on what the results of those questions are, we may have follow-up questions or other requests before we do onboard them as a vendor. So there's definitely a process like that. On the medical device side, we'll typically ask for things like MDS2 sheets. We have our own assessment questionnaire, and we've been increasingly asking for SBOMs where we can get them.
Yeah. Yeah. With those,
Yeah,
go ahead, Renee.
Get a little bit to that, regarding the whole vendor side, we have a security checklist with the vendors that we actually go through, and same thing, we look for, SOC 2s and, if they're a credit card company, all the relevant criteria. I think one of the things that has helped us is I'm also high trust certified. So I know exactly, as an assessor, so I know exactly, what organizations go through to get that in order to protect our information. And I think, we go through that process and ask for that. The other thing is, and I'd be interested to what Chris and Mo might have, we purchased a software that does real-time risk management, right? So we have our highest risk vendors, right? Our payroll system, and this isn't device specific, but you can put that in there. And our systems that contain protected health information, and it's real-time monitoring the risk, and we get alerts if there's been a breach of credentials, et cetera. So that's one of the other things we're putting in place, and that sort of is proactive so that the users are not necessarily so worried about that and know that we're kind of covering that thing. So.
Renee, was that a
we-
question? Was that something to run by your co-panelists?
No. Yeah, I mean, just if they're, if they have other tools that they've implemented that are just, like a tool like we're using Black Kite, right? And there's BitSite and all that. If they're implementing that, that's be helpful as well.
Mo, any thoughts on this?
Yeah, I think so. The healthcare clients that I work with that leverage, Armis, it's exactly that. It's understanding the real-time risk, and to Chris's point there, any deviations in behavior. And one of the things around medical devices or just the healthcare device ecosystem, I know we've been focusing a lot on devices, but to your point, Renee, as well, it's also user entities, it's also credentials, it's also phishing. There needs to be a multi-layered approach to protecting assets. Server is not only based on endpoint security, it's not only network-based controls, but it's also the users that are logging in, right? In terms of how are they able to access it. I love the point that you mentioned about risk classification, because I think really doing that work up front when we're talking about things like automation, when we're talking about even understanding the risk that devices pose, it's really important to do that work up front so that then we can map to it. I think a lot of times when I'm talking to security teams, one of the struggles they have is even understanding the risk, whether it's servers, applications, clinical devices and whatnot, because they're not entirely too sure in terms of their risk appetite, in terms of what are high severity risks that devices, applications, and so on can have, what are the different ways they're being used. So it's a really evolving world when we're shifting away from the enterprise side of the house. And I think collaboration as well plays a huge role. Right. So very impressive on that high trust and being able to understand the rigor that goes around high trust for security teams, tasking them with securing medical devices. A CISSP and other industry certified professionals, they'd be great at securing servers, endpoints, things of that nature. And they can translate a lot of that to, let's say, medical devices. But then biomed teams are really the ones that help understand this is how this device communicates. When we're talking about architecture diagrams previously, just kind of segueing a little bit back to the question, before it used to be what endpoints are accessing it. And that endpoint used to be a laptop accessing a server, which might be talking to a domain controller, database, and so on. But now that architecture composition has evolved. Now I need to understand what are the different IOMT devices that are connecting to it, right? Because if anything were to happen to that server and that server is talking to infusion pumps or it's talking to nurse call systems or what have you, that's direct impact to patient care. And we need to make sure that communication, those devices are on the appropriate network segments and they've been secured and restricted down to things like the network part. This is what the device should be doing. Any deviations, we need automated reporting. Why? Because this is a high-risk device. Why is that? Because it's dealing directly with patients, or the fact that it's processing PHI. That all kind of comes together in a holistic risk assessment of the entire environment.
I just want to build on the risk part too. Is I think one of the mistakes a lot of times is made in healthcare is we consider cybersecurity risk. We only consider it in the traditional sense of asset value or this type of data. I think one of the things that increasingly needs to be done is to incorporate clinical context into it. I think not enough times do we consider the patient care aspects as part of the cybersecurity risk equation. Take, for example, two CT machines, one in an emergency room setting, one in an ambulatory setting. that CT in the ambulatory setting, if it goes down because of a ransomware attack or something else, I mean, it's inconvenient because you have to reschedule some patients, but it's not going to impact the larger mission of the organization. That same CT machine in emergency room setting, and if it goes down, now you can't triage stroke patients and certain other conditions, and that's a huge problem medically. And I think increasingly we need to partner more and more with the clinical side of the house and actually figure out what the patient safety risks are to a lot of these devices if they were to become impacted by a cyber attack. And I think that's a missing piece of the risk equation in a lot of healthcare security groups.
And I think to that point, the context of the devices, it's a matter of right now they're large buckets of, we're really good at the IT, and then there's medical devices. But even within the medical devices, to your exact point, how is this device being used, right? Is it being used in the ER? What's the business criticality of these devices? And then on top of that, even when we're doing a passive vulnerability assessment, now it's not enough that the vulnerability in terms of exploitability metrics and the ratings that NIST has provided are enough, in my opinion, right? Yes, it's a CVSS of 9. Yes, it's remotely executable, but now what's the clinical context of the device? So if you have this vulnerability across 1,000 devices, but now you know that this device is a medical device and it has utilization activity, it's directly touching a patient, that's probably going to be your highest risk device, especially if it's accessing the internet, especially if that vulnerability is being exploited for ransomware and things of that nature. The fact that that clinical aspect of the device, it really elevates the overall risk it poses to the entire organization. And then, of course, patient safety as well.
Very good, Mo. Renee has catapulted us into the Ask a Co-Panelist section on her own without permission, but that's fine,
Sorry.
Renee. No, that's fine. Mo, did you have a question for one or both of your co-panelists?
Yeah, I'll throw it out for both Chris and Renee. A lot of times when I'm talking to executives, the conversation, just given the impact that COVID has had, it's now a organization-wide focus in terms of increasing operational efficiency, in terms of cutting costs, amalgamating tools, and things of that nature. How are you finding if you need to bring in new security technologies, or how are you justifying additional purchases during this time that I think healthcare is really strapped for resources, whether it's capital, whether it's human resources, and so on? I'd be curious to get your take on it.
Renee, you want to jump in? You want to start?
Sure. So, I sit on the executive leadership team, so I'm fortunate in that respect, right? And so I have not met any resistance, believe it or not, because we sit on such a significant amount of confidential and, protected data. I don't generally have an issue bringing in something new. My best approach is because I put the framework for security in place, I have a strategic plan. I report regularly on it. We have training. We have automated training through tools. They embrace the security. They embrace security very well. I have not had a problem to date. I mean, I'm not asking for $10 million either because I'm not that big of a company, but I present my business case and say, this is how you'll do it. And, and periodically I bring back examples of how our different tools are supporting. So when I make my business case for something new, which I'm in the process of doing right now, I generally don't have much pushback. I might get asked questions. I might have to find alternative funding methods, but for general purposes, I don't have an issue with it.
Chris?
We're pretty paranoid where I am.
I haven't encountered too many issues with budget due to COVID, because I think one of the interesting things about COVID is it really illustrated that healthcare systems that had heavily invested in technology were very able to scale and to adapt to meet the challenges of the pandemic. So I think in a lot of ways, it actually made it easier to encourage IT spending, because it, for the first time, showed a lot of the value of what IT and technology could do to help the organization adapt to situations like that.
Very good. Chris, do you have a question for one or both of your co-panelists?
I guess since we're talking so much about devices, one of the things I was involved with the Cloud Security Alliance a while back is we did a medical device incident response playbook, where we took the idea of clinical context we were talking about and applied it to incident response. Because the idea is like, let's say a common incident response thing is to unplug a PC because it can stop something from spreading, which works for a PC, but you can't do that as a respirator. And that's kind of a crude example, but I'd be curious to know if there's any thoughts, I guess, on combining clinical context with incident response.
Mo, let's start with you.
Yeah, for sure. I think this is the water that's untreaded right now in a lot of different organizations. And whenever I'm talking about medical device security or to executives, I think that's the key that I drive, is that collaboration, because it's important to understand, even from the first place, what's the impact if I do unplug this device? So is that even a viable step if we're having incident response procedures at this point, right? So if that medical device has been infected, if it's directly touching a patient, what's the lesser of two evils? Do I unplug it? Will there be any adverse impact? Versus we might need to leave it online, but in real time, we're going to block all the network connections that device has and kind of localize it. I think there's now starting to be a lot more conversations between security and clinical engineering teams in order to understand that. And I think there's a big push understanding that from a reactive state, it's very, very difficult to manage once a device has been compromised. There's a huge push on the proactive part. And one of my favorite aspects to discuss is something you mentioned earlier, Chris, are the MDS² files, right? So those files that have information on privacy and security controls medical devices can take, a lot of times are only really available to biomed teams through support portals for vendors and what have you. Really getting that information, helping provide it to security teams to be able to reduce the attack surface up front, I think that goes miles ahead in terms of understanding what can be done on medical devices, helping reduce that, and then running playbooks against it.
Renee, your thoughts?
Yeah, I mean, I can mirror most of what has been said already, but we do have an incident response plan, right? And so we do exercise it, on a regular basis. However, as we started off in the beginning of the conversation, we were talking about the universe of things that happen or devices that might connect. And I think that, we often do things, and maybe my colleagues can comment on this too. We make these documents, we make these procedures and all that, and then are they living and breathing documents, right? Are we updating them to contemplate the future or the universe or whatever, so that when we have a situation like was just described, that we don't find out 3 days later and meanwhile everything's gone south, right? So we try to be proactive in that, and part of that proactiveness is having that plan, but also anticipation and making sure that it stays regularly evaluated and modified accordingly.
All right, we're just about time for some final thoughts. And maybe I'll just give everyone a specific little shading of a question. Chris, you've done Zero Trust twice. I don't know if you're done with it the second time where you are now, but I don't know if anyone has ever done with it. People describe it as a journey, and I don't know if you ever crossed the finish line and put up the mission accomplished sign. But I think a lot of people get intimidated by it, is my guess from talking to folks, and maybe that scares them from getting started. But you sound like you would be a big proponent for this Zero Trust approach.
I definitely am. And I think the key there is it's a journey. You're not going to flip a switch and one day have zero trust. And if you try to do it that way, you're going to break a lot of stuff. It's about breaking your environment up into manageable chunks and deploying it over time. And it might be something you make increasingly fine-grained over time. Maybe you make some coarse cuts first and then begin to make it finer. But it's really about finding a way to divide the environment up into manageable pieces and not to try to do it all at once. I think trying to do it all at once is a recipe for disaster. And it's so it really is the journey, as you say, and not the just an end goal that you can just flip a switch on and arrive at.
And have the party where everyone meets for the Zero Trust is finished party. I guess that maybe isn't going to happen. Renee, Mo loved your talk about risk classification. You want to give us any more on that before we let you go?
No, I just, I think that that is an important piece of it, because it plays into so many things that we've been talking about today, like, alert fatigue, right? Like how many alerts are people going to get on different things? But also it creates the opportunity for you. It's probably a big step as you do your governance, as you do your strategy around security, like what is the risk, and doing those appropriate risk assessments so that you can build that into the culture, build that into the plan. Build it into your alerts, whatever your technology. It is really key to understanding how you want to manage. And again, not all things are the same risk, right? And so you have to have that so you can respond effectively. And that's just an ongoing process that you have to be constantly aware of.
Very good. And Mo, so you worked in a health system or a hospital, correct?
Yes, sir, I did.
So you put some time in the trenches, so you know what of you speak when you talk about this stuff. Tell us a little bit more. Tell me a little bit more about your time in the trenches.
Yeah, absolutely. I think it was I was fortunate in the sense that I got to see a whole bunch of different aspects of growing and implementing a security program. Um, I think there's definitely a difference in the way healthcare environments are handled versus enterprise environments. When you're looking at things like ransomware attack, it's, to Chris's point, it's there's certain steps that you can take, certain steps that you got to kind of think twice about before you do take. And I think it really puts an additional lens on cybersecurity when you're taking into account context and clinical aspects of devices and, the uptime of services in a hospital. It's really interesting to see that, downtime procedures for hospitals result in, hey, we got to revert back to paper charts. We got to do what's necessary in order to be able to maintain the delivery of services. It's not that we're just shutting down a business and we'll be back up in 8 hours or when we're recovered. It is, there needs to be continuity planning. So when we're doing cybersecurity, keeping that in mind, but also baking that into any type of downtime procedures. When we're bringing in new innovative technologies, well, hey, we still got to maintain the other side of the house. So if there is this great innovative technology and we're reliant on it, we can't let go of some previous processes, no matter how much we'd like to move away from paper.
Excellent webinar, excellent discussion, lots of incredible stuff in there and good takeaways for people. Regarding continuing education, you can use the final slide in this deck. You'll get an email recording when the on-demand version of this webinar is ready for viewing. If you want to sponsor an event with us, you can reach out to Nancy Wilcox from our team, and you can go to our website to register for upcoming panels. With that, I want to thank our tremendous panel, Renee Broadbent, Chris Friends, and Mo Watkis, and I want to thank Armis for making this possible and sponsoring, and I want to thank you for attending. And with that, everybody have a wonderful day. Thank you.
Thank you.
Great. Thanks, everyone.
Bye-bye.